So welcome back to July's governing body meeting in public. We've had apologies from Louise Lester and Victoria McGregor Riley. Linz, can you send our best wishes to Victoria, please, and offer condolences on behalf of governing body?
Well done.
Thank you. Any changes to declarations of interest? We've had no, just confirming, Sarah, we've had no questions from members of the public. There was nothing as of yesterday.
No more questions now.
Thanks, Sarah. So I'd like to confirm that we are correct. So next on the agenda is approval of minutes. So just bear with me a sec whilst I'm scrolling down. So approval of minutes from previous meetings. So the 18th of May meeting, 1, 2, 3, 4, page 5, page 6, page 7, page 8, and page 9. Everyone happy? Can't see any hands up. And then to the minutes of the 15th of June meeting. 1, 2, 3, 4, 5, and 6. Sue?
Yeah, on page 5, I should have probably spotted it sooner, but under the audit committee update, in the middle paragraph, the fourth one down, where it talks about the financial stability being rated as amber, it should say that financial stability was risk rated as amber at the planning stage.
Okay.
And then, however, they were then happy with their mitigations.
All right. Thanks, Sue. Is that okay, Linz? Have you got that?
Thank you. Yeah.
Thank you. No other hands. So on to the action log. Finance performance report to be kept on the agenda. This is next. Efficiency plan and rapid diagnostic centres have been deferred, and the remuneration committee has met virtually, and that's been complete. So no outstanding actions. Quick shares report. I think we hit Freedom Day, or whatever it was now called, on Monday. Yesterday. It was interesting popping in some shops. Popping into my local Sainsbury's last night, I think I was the only person wearing a mask. So restrictions have seemed to have eased a little bit, but infection rates still keep climbing, and hospital admissions are slowly creeping up as well. I'll know this will be updated later. We're continuing to roll out the vaccines across our free PCNs. And most I think all 3 of our PCNs are doing drop-in clinics for the 18+-year-olds, as well as sort of book clinics for first and second vaccines. I think things have slowed down a bit, but looking at our local numbers, we are still well ahead of the national figure. So again, well done, everyone. As you know, we have a new Secretary of State. At the time of typing this, I wasn't sure whether the Health and Social Care Bill will have its initial readings or not. Idris updated me on Friday that they've actually had their first and second readings, which didn't seem to make much press. All was quiet. As usual, we're continuing to operate as business as usual for the CCG. We're still awaiting a decision on boundaries, and we're working closely with partners, particularly colleagues in DBHFT and also in Notts Healthcare Trust in their community nurses, looking at how locally we increase activity to actually try and make a dent in the backlog. And as we know, some schools have finished, some schools are finishing this week. Summer's upon us after the tough 15-16 months we've had. Hopefully, despite the fact that it looks like none of us are going to get particularly far abroad, hopefully everyone might have a little bit of time to refresh their batteries, ready for business as usual after the summer break. I'll hand over to you, Idris.
Thank you, Eric. I think partly to elaborate really on some of the things that Eric has pointed out, I think we're identifying some very similar themes at the moment, understandably, both in terms of potential organisational change. And as you know, there is a question with regard to the boundary. I am hoping that we will hear whether we're remaining in part of the South Yorkshire and Bassetlaw system or moving into the Nottinghamshire system very shortly. So as soon as I hear, I will let governing body know. But we are making plans for either scenario, but it will be easier if we hear sooner rather than later. Just in terms of COVID, yeah, I did my spot check in the local supermarket as well yesterday. And apart from the staff who weren't wearing masks, almost every shopper in Lidl was wearing a mask. So I commend them. I may have a word with the management of the staff there. From a workplace perspective for the CCG, we are not making any immediate changes to our working patterns. So there are some people who are regular attenders on site and have been throughout the pandemic and have been providing excellent services, that's been helped by us being able to accommodate them back in the offices. But many people have been working very effectively from home. So we will continue with that for the time being. The Retford Hospital site, of course, is a clinical site, and therefore it will be following the same rules as every other hospital, I think, now is adopted, which is maintaining masks and social distances. Obviously, we deal with the most vulnerable of society. They come through our doors, even from a Retford point of view, and therefore they deserve our sort of protection. And I hope that will go for all members of the public when they make their personal choices about whether to wear masks or not, that they think about those less sort of fortunate and potentially more at risk than they are. Just want to add my thanks and support, particularly to the primary care networks in Bassetlaw, who have done an outstanding job with regard to vaccinations. We're at over 85% of the adult population have received the first vaccination, and 70% have received the second dose. The numbers are quite outstanding, really. They do perform and compare incredibly well with the England picture. And South Yorkshire has done, I think, very well, but we're probably at the top of that as well. So a fantastic job. But I would really encourage those who haven't had both their vaccines to come forward, and particularly those younger people. Say that now I'm the age I am, but if they can come forward, it's very convenient now. Most places are doing the drop-in clinics. They can either do it in mass vaccination sites or through their PCNs, yeah, it helps protect them and the public. The rates in Bassetlaw are sort of increasing. We're 378 per 100,000, last figures I had. Compares better than Notts, 310 per 100,000. Bit worse than the England overall picture of 342 per 100,000. But some areas are being hit really hard and are seeing rates of well over 1,000 patients per 100,000. And some of those areas, and some very close to us, are seeing an increase in admissions as a consequence. So we've got district general hospitals not a million miles away that have got approaching 40 inpatients with COVID, and are seeing increase as well of patients in their intensive care units. It will be interesting as time goes on to see how many of those have had both their vaccines for a number of weeks after the second, how many of those are still being admitted. With rates of COVID so widespread, and I suspect we all know somebody who's been pinged and is self-isolating. Yeah, it seems more common than ever, just sort of anecdotally on that level. But we are seeing those admissions, and of course it doesn't provide complete protection. So there will be people who are incredibly vulnerable with rates like that will be admitted and will become seriously ill. And I think as a society, we will sort of reflect and decide so what the best course is. I fear we may do that retrospectively, but I think from an individual perspective, we can all make the sort of the small but very effective gesture of a bit of space and wearing a mask, particularly in closed places. So I think the least we can do. So Eric mentioned about the recovery of services. From a South Yorkshire and Bassetlaw point of view, we were increasing our elective activity very effectively. And the previous couple of months, we've seen that go up very close to pre-pandemic levels, which, considering all the restrictions and challenges that we continue to face, I think is excellent performance, both in terms of primary care, but also secondary care referrals and treatments for individuals. That has become a lot more of a challenge this month as the rates of COVID have increased and the number of staff that are having to isolate has increased. Now, you will have seen that criteria are being adjusted to allow those that have been double vaccinated, even if they've been contacted by the app, as opposed to test and trace necessarily, then the assessment will be made and they'll be able to return to work. And there are hundreds of hospital staff across South Yorkshire and Bassetlaw, many hundreds, who are currently self-isolating. So hospitals are under a high degree of pressure. The number of patients going to A&E remains very high. We've hit some record levels in the last few weeks, months. So again, I would urge those that aren't acutely ill, haven't had a significant accident, to actually see whether they can open the medicine cabinet, get down to the pharmacy, get a bit of advice from them, call 111, and if you are sort of quite ill, GP practices are open for business and seeing lots of patients. My own practice last week was fantastic for me. I commend them. Yeah, general practice, very effective, providing great care in my personal experience, and I will leave it there. I think Sam's going to have it.
Thanks, Idris. Sam?
I just wondered if there was any data if people have contracted COVID for the second time and may have been double vaccinated.
So I don't have that level of data yet, Sam, and I think the numbers are still quite low, and we'll have to see over time. Between 20 and 30% of the admissions in some hospitals have had both vaccines. So it's difficult to tell about whether you are serum positive, i.e. you've got antibodies without doing the blood tests and things. And so that takes quite a bit of time to build those numbers and get a really clear picture. But the hospital with the highest admissions locally were recording that 20 to 30% of those admissions had both the vaccines.
Thanks, Idris. Any questions for Idris or myself before we move on to Nicola? Nope. Nicola Cortian, patient safety, and then the child neglect strategy, please.
Yeah, okay, so if I start with quality and patient safety, so obviously the first item on the paper is around our annual health check. So I can now confirm that we were top in the country at 92%. I did think we were when I wrote the paper, but it's been confirmed. Big task for next year because quite a lot of other CCGs nationally were in the high 80s. So to retain our position, we've got lots of hard work to do, but it's really positive. And we did recognise very early on what the challenges were as part of COVID. So that's really good news. Our Maternity Voices partnership goes from strength to strength. So we relaunched last year to support the trust and gain the voice of pregnant women and their families. We struggled to appoint a chair, so in the interim Sam chaired the meeting, but we're now able to confirm we've got a chair, an interim chair for the MVP, which is really, really positive. So obviously I want to acknowledge the work that Sam's done in chairing and supporting Sarah with that. It has been hard work, but we're now building up a group of mums that are really keen to offer their help and support around the Maternity Voices partnership. So we're really pleased with that. Continuing healthcare continues. We're still following the National Discharge Scheme till the end of September, and we're just working through with partners what that looks like post September, because the national funding will cease and organisations will have to provide their own funding for their own services and the discharges. So we're just working in partnership with Notts Healthcare Trust, the local authority and the trust around that. I'm pleased to report that our outstanding reviews are decreasing. We are monitoring them on a weekly basis, so it looks like we should hit the trajectory of Notts Healthcare Trust in September or by the end of September, so that is really good news. The care home audit programme, we've commenced our new programme with a selection of visits, so we're visiting elderly care homes once per quarter and the LD homes every 6 months, and that seems to be working really well, and obviously we'll evaluate that at the end to see if that's been a more effective audit as opposed to just a one-day visit. So that's really good. And finally, the LD acute liaison role, which we brought back into the CCG from the acute trust, is going from strength to strength. Evie's been able to do quite a lot of work now with the trust around the ambassador programme, raising the profile of learning disabilities in the acute trust, which goes alongside the work that we've done locally around learning disabilities. And I'm just exploring with Evie whether we can offer some of that ambassador training to our GP practices and also perhaps some of our CCG staff. So I think we're in a really good place with learning disabilities, and through the appointment of Evie and some other roles within the trust, they've really raised their own profile, so that's really good. So that was that paper. So I don't know if anybody's got any questions. Okay, and then the next is the early help strategy. Oh, Idris, sorry.
Sorry, I was really slow off the mark then to try to get my.
I thought I was moving on quick to avoid a question.
Well, you'd be relieved it's not a question, but I just wanted to come back to your first point that being the best in the country for learning disability health checks is absolutely fantastic. And you know, we're a small CCG, and you know, we say that we punch above our weight, but you know, that is a fantastic achievement by any measure. I just wanted to commend Nicola and her team, you know, sort of, and all the practices that are managed, you know, sort of to get us to that point. But it's always nice to say top of the country, isn't it? I just wanted the opportunity to keep saying it.
we can live on this for the rest of the year. And then the next paper is the Nottinghamshire Early Help Strategy. So this has been developed by the Nottinghamshire Children's Safeguarding Partnership. It's a 4-year strategy, and obviously the Safeguarding Partnership will be monitoring the implementation of the strategy. The key aims of the strategy are to recognise when there's neglect, particularly for children and young people, respond to the issues, and then reflect and review what we do going forward to manage neglect. We do know that a lot of children who have experienced neglect end up on a child protection plan, so it's really important that we support partners in delivering the strategy. So I'm not going to say any more about that. Obviously, I'm sure people have read it. I think it's a really good piece of work and gives us some direction and supporting children and young people coming out of COVID. Sue?
Yep, I agree, Nicola. It is a really important strategy. I was just surprised on the organisations and partners that are signed up to it. We're not listed.
Are we not?
No, it's all the only. it doesn't seem to mention any of the CCGs. It mentions Mid-Knots Integrated Care Partnership, but it doesn't actually make any reference to any of the CCGs, and that just seemed a bit of an oversight.
Yeah, I'll go back to them and ask.
We are all signed up to it, and it would be good to have that clarified.
I'll go back to Colin Pettigrew and ask him if we can add that in.
Yeah, thanks.
Thank you. Any other questions or points for Nicola? No, thanks. Nicola Haley, financial report and annual reports and accounts.
Thanks, Eric. Apologies for my connection, but I've had to swap to my iPad because my computer's just died on me. So hopefully this will work. So I'll take you through the first financial report for 21-22, and I'll just pull out the key points. As ever, I'm really happy to answer any questions. So this is the first report, which is May. And just to remind governing body members that we're still in the temporary financial regime. So we're in what we're calling H1, which is the first 6 months. And that goes from April to the end of September. So the temporary financial regime still means that we're on block contracts with our NHS providers. Our allocations are nationally determined. And we've still got some allocations which are still to be clarified and announced by NHS England. So in terms of this report, we are submitting at this stage a technical overspend for the first 2 months of 125,000. And then for the first 6 months, bearing in mind this is only for 6 months, we are submitting a technical overspend forecast of 329,000. Now, that is very much predicated on money that is due to be given to us in relation to the hospital discharge programme. So, and I'll take you through the risks in a little while. So, I am expecting that money coming through, but there is a slight risk with it. The other things I want to pull out of the report are we've got the electric recovery fund, and we think we've got a best case scenario of accessing 317,000, which is predominantly around the independent sector. But we've got very, very little activity reported so far. So we've excluded that, and in the coming months we'll update governing body. Mental health services, discussions are underway with Notts Healthcare. We had a useful internal meeting yesterday, so we'll be taking that forward to agree the investment level. But we're expecting to fully achieve the mental health investment standards, so that's really positive. In terms of primary care, we've got the additional roles reimbursement scheme. Funding's yet to be confirmed by NHS England, NHS Improvement. We're expecting in the region of 1.6 million pounds, which is full year, and we're expecting that to be fully utilised by the PCNs. So just coming back to the main risks, the hospital discharge scheme, we've now got a financial envelope for South Yorkshire and Bassetlaw of £5.8 million. Yeah, £5.8 million. And that is slightly overcommitted at the moment in SYB in South Yorkshire and Bassetlaw by about £500,000. So I know the other CCGs are looking at their forecasts and trying to get them as robust as possible. But there is a meeting next week, a regional meeting next week. I think after the other CCGs have looked at their forecast, I personally think that will be in that £5.8 million. So therefore, I think we will get our forecast spend on the hospital discharge scheme, but it is a risk that it is worth noting. The other risks are if our costs do increase above our allocation, so I'm thinking about continuing healthcare, prescribing, even though the first month is below our profile spend, but prescribing has everything. It's very, very early days, and because of the time lag, which is 2.5 to 3 months in terms of that collection of information, there is a significant issue if we do start overspending there. And I think the other thing to raise is if we do start spending over and above what we've allocated for mental health services. The other risk is around the access of the elective recovery fund that I've already alluded to, and I'll keep governing body informed over the next few months. And I think then finally, it's the next 6 months uncertainty. I very much feel that the H1, the first 6 months, will be much, much easier to achieve. I think it will be very challenging in terms of the final 6 months of the year. There was an initial call, not last week, the week before, with the Director of Finance for NHS EI, which set out some of the initial principles of H2, the final 6 months, and it is going to get a little bit tougher. So I think our plans will have to be in for October, may even extend to November. But again, I'll keep governing body informed. There's lots of conversations with Treasury, and that will no doubt play out in the next few months in terms of what that financial regime looks like. I don't think I've got anything else at this point in time. It's very early days. But I'm really happy to answer any questions.
Thanks, Hayley. Hesh.
Thank you, Hayley. Just a quick question around the elective recovery fund. Am I right in my interpretation that you said that we've got access to about 350,000 potential?
317,000.
317,000. Predominantly from the independent sector, but at the moment the returns from independent sector are small. So does that mean we have an opportunity to utilize the independent sector to try and reduce our backlog within?
Potentially, however, it depends on whether the acute trusts are also accessing that independent sector as well.
Okay. Do we have any influence in terms of trying to encourage a repatriation from the wait lists to the independent sector if there's potential there? So for example, if patients are, depending on how long they've been waiting for, depending on who has the capacity to try and get these patients treated, if you like, or are we at the mercy of the secondary care trust kind of coordinating all of this?
It just has helpfully got his hand up now.
Okay, thank you.
Hi, some of you will know or recall that I'm the Senior Responsible Officer for South Yorkshire and Bassetlaw on electives and diagnostics. So all organisations across South Yorkshire and Bassetlaw have entered into contracts with the independent sector that allows us to transfer patients into the independent sector. From a Doncaster and Bassetlaw perspective, probably our single biggest challenge is orthopaedics and long waits, most of which, of course, because they are long waits being on the waiting list for Doncaster and Bassetlaw hospitals for a considerable length of time. So we've been facilitating sort of work to allow patients to be transferred from DBH into Barlborough in particular. Barlborough used to do a significant amount of orthopaedic activity for Bassetlaw residents, some of whom went through the DBH route, but then were treated within Barlborough, others directly referred by ourselves. Those that are directly referred and are long waits are now being seen. Throughout COVID, until now, we've had very limited, if any, access to Barlborough activity because of the national contracts with the independent sector. but that's now been replaced by these local contracts. So for the first time, really, we're able to get back activity up and running in Marlborough. And they're doing that, so plans for 40 cases per month initially, but hopefully that will rise significantly in the future. So yeah, that's been carried out. We're also working with both providers and commissioners, but like I say, most of the long waits are held with the provider and on their list. So they're looking around the use of Park Hill and other independent sector providers, some of which are in reach, some of which more community-based providers. So a whole range, really, of options. It is being helped by the fact that we are an accelerator system, which basically means that we're one of the systems in the country that's received additional funding to try and get up to and above pre-COVID levels of activity. So as a system, we've received £10 million to support that work. And there have been, for example, a series of meetings or workshops, I'd say, rather than meetings, particularly with clinical staff in particular specialties. So orthopedics is one, ophthalmology is another, gastroenterology another, where we're seeing from a clinical perspective, how do they feel that they can increase the amount of the number of patients being seen, so we can try and address this sort of very worrying backlog of patients. And quite innovative ideas are coming out of that, in addition to some of the old ideas coming forward, which is fine where they're effective. So I think it's a steep hill to climb, but we're going in the right direction on it, and we are seeing sort of more uptake of the range of capacity that we have available, both in the independent sector and the NHS to support NHS patients. That was a long answer, wasn't it? So apologies for that, but I'll remove it from my updates on performance when I get to it.
Very helpful, thank you, Idris.
Thanks, Idris. Any other points or questions to Hayley before she moves on to annual reports and accounts?
Okay, so moving on then to the annual report. Essentially, this was considered and approved by the Audit Committee on the 27th of May under the delegated authority that is given by the governing body. There is a link in the report to access both the annual report and the accounts, and it is published on the website, and it's brought here just for noting for governing body. I didn't anticipate saying anything else, Eric, but again, I'm always happy to answer any questions.
No, that's perfect, Hayley. Thank you. Any questions or points before we move on? No. So, Idris, performance.
Thank you. I'll be brief on the points that we touched on before, and then sort of elaborate on some other aspects of performance, then happy to answer any questions. So I mentioned earlier in the meeting that our A&E activity is at all-time highs, and you can see that in some of the numbers that are coming through on the performance report. I think the achievement of 86% of patients being seen within 4 hours against the backdrop of those challenges is actually quite good, but I'm not encouraging people to attend A&E unnecessarily, simply because 86% of them may get seen within 4 hours. We're looking at a range of sort of issues in terms of trying to address that demand, but I think largely it's a plea to the public not to use A&E where it's not necessary. In terms of electives, 72% are still being seen within 18 weeks. Obviously, a lot of those are sort of cancer and urgent cases, but we're also seeing some routines in some certain specialties getting back on track, which is really positive news, but a very significant backlog of very long waits. And I think it will take quite some time really to address that. And depending on other challenges, and we talked about that in previous discussions this morning in terms of COVID, urgent care, staff availability because they're being self-isolated. All of these issues are perfect storm really against our plans to try and recover that elective activity. If some of those can resolve and improve, then obviously we can get back on that track of resolving those long waits, and hopefully we'd see a significant reduction by the end of the financial year. But at the moment, the challenges are outweighing the efforts to an extent. And in diagnostics, we're seeing still some challenges in particular areas. MRI, CT, non-obstetric ultrasound is a very widespread issue, and endoscopy, of course. On a wider footprint, and it will help us as a knock-on effect if and when these go ahead, we've got bids in as a system for rapid diagnostic centres, both at Mexborough and in Barnsley at the Glassworks. And some of the focus around those are in CT and endoscopy and non-obstetric ultrasound will help us in terms of the wider population. So not directly for Bassetlaw residents necessarily, but it may free capacity up, for example, in Doncaster. And we're hoping that they will be in place later this year. Ambulance service has been, and this goes for Yorkshire Ambulance Service as well as EMAS, have been under significant pressure and with sort of quite long waits to be able to dispatch ambulances, and we're seeing that in the performance sort of across the board. So this isn't a local problem, it is very widespread, and you can see that the increase in calls for the CCG are nearly 12% compared to the previous period last year. So very significant pressure on our emergency services as a whole. In other areas, in control of infection, for example, and actually diagnosis for dementia and one or two other areas, CAMS and the talking therapies have been performing extremely well, considering the pressures that they're on, which is very positive to see. But I'll close it down. Happy to try and answer any questions if there are any.
Thanks. Idris Hession.
Thank you, Idris. Just a couple of things really from me. One is more of an update in terms of A&E or urgent care, really. I chaired a meeting at Bassetlaw Provider Collaborative last week or the week before, where we talked about A&E activity, especially in relation to the children. And you know that one of my areas of interest is actually kind of promoting self-care and empowering patients to make choices, the right choices, really. So certainly for children, South Yorkshire and Bassetlaw has adopted this standardized way of giving advice called the Healthier Together website, which I did share with Alison Knowles as well, and she was going to promote that across South Yorkshire more formally as well. And Tim Noble was supportive of A&E using that website and the information on there to give standardized self-care advice and advice around how long minor ailments will last for. So rather than us sort of diverting activity between each other, is whoever sees that child on the first occasion will give them some standardized advice, so that hopefully will reduce demand coming from the second event. So when they develop the same symptoms again in the future. So that's one point. So that was quite a positive, I think. Again, the devil will be in the detail in terms of implementation, which again I will try and pick up at Bassetlaw Collaborative in terms of how we're going to do it and how we're going to measure that, etc. So that's one. The other one that we talked about was diagnostic waits. You've clearly highlighted long diagnostic waits. One thing we have requested from secondary care is whether we can have timely access to diagnostic waits in a real-time basis. So at whichever frequency that the trust feels is appropriate and sustainable. So whether we could get either a weekly or fortnightly updates to primary care saying the current wait for non-obstetric ultrasound scan is X, so that when we are having conversations with patients, we can give them realistic expectations of how long things will need to wait. And my personal view is sometimes certain things get better before you wait for the diagnostic. So if we're able to tell them there's a long wait, let's watch and try other things, things might then go off and get better, and therefore we wouldn't probably burden the diagnostic wait even further. So that was one, and I've tried requesting this from Sarah Elliott and Jazz. It's not really been forthcoming. Tim was going to chase them up as well, but whether we as a exec to exec, whether we could have another conversation with DBHFT to try and see whether we can get some real-time data. And my last comment is around stroke. Faye's doing some stroke work around stroke, and we get this data on a very regular basis around stroke performance. And I wonder whether there's some way of actually us formally sharing this data on a real-time basis with Faye, so that this stroke improvement plan that DBHFT is implementing, we make sure that that plan addresses the challenges that we have highlighted from our stroke performance data. Because what we don't want is a stroke improvement program and our patients being left with the same challenges going into the future and those not being addressed. So those are my 3 points. Thank you.
Thanks, Heshen. I think just a yes to all of those, and we will take up the diagnostic weights, so from an exec to exec point of view. But yeah, very happy with the points that you've just raised.
Dr. Kumar.
Hi, thank you. Heshen, I think I gave a feedback on the Healthy Together website. I think I sent a reply back to feedback to Idris. I think actually I found that the Nottinghamshire one were much more friendly than the South Yorkshire and Bassetlaw one. It's simply because if you look into the parent and carer advice, the actual advice is good, which is in par with the Nottinghamshire one. However, then you got next tab about professionals. And then if you look under primary care, it talks about pediatric abdominal pain pathway. And I'm going to give this link to a new mum. And I don't want the mum to see a pediatric pain pathway for abdominal pain. So it's a bit of a concern to me. So I've just fed that feedback to Idris and Victoria. Sorry, Heshen, I didn't give it to you because I thought I gave it to Richard, and Richard Davey will feed back to you. And on that email, I also highlighted some of the Nottinghamshire one web links as well, which are very friendly, which really breaks down into age group and how to do that. So it's something that I take that Idris would discuss with the ICS level and see whether anything could be changed, or Heshen, you could take it further. Thank you.
If I just come back on that one. There are several versions of this because it was initially developed by somewhere down south, the CCG down south. So the safety netting advice is pretty much standard for everyone. In terms of the individual pathways that are locality specific, there's an SYB version and a Nottinghamshire version. So when I tend to share this, what I tend to do is I tend to tell parents that it is the safety netting element of it that I'm giving, which is standard to all patients. In terms of the clinical pathways, that might be different in terms of their availability across Bassetlaw, across Nottinghamshire, etc., etc. So yes, it's important. There is an SYB specific link, which is not as all-encompassing as the one that's been developed down south, but make sure when you are sharing that is the SYB one, which hopefully should mirror some of the pathways that we've got locally. But if you do find things that are not even available across SY and B, then there is there's a lady who came and presented it at Best. I can't remember her name now, but that lady was very, very happy to receive feedback from GPs who are using it to say if there's any points of clarification that they need to include. Andrew Beardsall should hopefully know the name of the person who brought the Healthy Together website to Best and promoted it. So we can certainly try and share that with you so they can give direct feedback to the authors.
Yeah, thank you, Heshen. And I think as a CCG, I'll share those links, and we could discuss at the SDC, because there is an app as well, which are quite useful, and they're all Nottinghamshire facing. However, the safety net and the reassurance are all the same, as you have rightly pointed out, and that's the main aspect we have to focus on. So I'll email you, and then we'll have some discussion further, and therefore then we can roll it out across all our colleagues, and we'll give a standardized care. I'm totally with you behind Heshen to give a standardized advice. I mean, that's vitally important. Thank you.
Thank you. Thanks, Hesh. Thanks, Kumar, and thanks, Idris. Comms update, Sam?
Yeah, I think this just follows the conversation flow that we've had, particularly around the vaccinations and the Bassetlaw Maternity Voices partnership. Just to add that we're going to restart the PP group chairs meetings on a bi-monthly basis. The first one will be arranged in August, and we'll do that virtually. And I think there was, in terms of, it's just promoting the vaccination programme, and Idris, as you alluded to earlier, around the younger cohort and encouraging the comms messages tailored to encourage those people to take up the vaccination. So that's all really.
Thanks, Sam. That's plenty. Any questions or comments? No. So, audit committee update, Sue? You're on mute.
Apologies. Not very much to add, to be honest. It's fairly self-explanatory. It's a relatively quiet audit committee that we've had. The main thing we had and the time we spent discussing was the counter fraud annual report and the self-assessment that I mentioned last time. So the real focus of the discussion was making sure we're going to be fully compliant with the new standards going forward. And Amanda gave us assurance that the work that they're planning to do during the year will ensure that. So unless anybody's got any questions, nothing further I really want to add.
Thanks, Sue. Okay, primary care committee update, Sam?
Yeah, and again, this follows the same kind of flavours around vaccinations. It was great to have Health Watch come along to the committee, and 3 patients who had been diagnosed with long COVID, and to give feedback initially on research around people accessing services with long COVID, and it was quite positive what we were doing in Bassetlaw already. We've seemed far ahead of other areas on that. And the other thing is around, we talked around the incentive scheme, and I think we've got to get the balance around not being burdensome on primary care, because we appreciate the demand on GP appointments and the need to return those to pre-COVID levels. Just on that data, the data is slightly out by about 13 on the demand on GP appointments, so I will get that data checked. And Nicola's already commented on the excellent learning disability health check achievement. I think the next, we did discuss around just going into September and the booster vaccination programme planning, along with the flu campaign as well.
Thanks, Sam. I think most of the GPs on the board would like to get appointments back to pre-COVID levels, not the levels that they're currently at. We'd like to reduce them back to the pre-COVID levels. Any questions or points for Sam? No. So sticking with vaccinations, Idris, COVID vaccinations, flu update, respiratory viruses.
Yeah, I'll be brief because I think we've covered quite a bit of this previously, but partly for the record. So we've delivered 152,000 vaccines, if you add them all up, which is fantastic. So again, well done to all of those involved, particularly the PCNs. We've got 4 care homes with outbreaks at the moment, but they are quite small outbreaks, so we're monitoring that very closely. But obviously it is very disappointing and worrying that we do have sort of outbreaks in some care homes now. We went for quite some time without any, which was really, really positive. So far, we only have 2 inpatients with COVID, active COVID in Bassetlaw, but 14 in Doncaster Royal Infirmary, and double to treble that in 1 or 2 other local hospitals. So I've made those points before, just to mention. In terms of the flu update, obviously flu is now being ordered, ready for the winter. We are looking in line with the national sort of plans about the possibility and how we could co-deliver a booster COVID in addition to the flu vaccine programme. which I think will be challenging, as you can imagine. We've reviewed our really good performance actually on flu vaccinations from the last winter. There are areas that we could target to even further improve. We did do really well on learning disabilities, I'd like to point out, and that was an improvement from sort of previous years. And so it'd be great to sustain, you know, sort of that. But we had less good performance on areas such as young children, preschool children, and pregnant women. So the numbers are not huge, although school children is sort of quite a bit bigger. So we will be doing some more targeted work on that. And then obviously there's the 2 to 3 year olds as well to be done. So our flu plan was, our initial flu plan was presented to the A&E delivery board last month. They will oversee and sort of sign and monitor off progress against flu. And the vaccine programme is just around the corner. So we're preparing with that, as is every practice. So those there on that, Eric. Thank you.
Yeah, great. Thanks, Idris. Any points or comments? No, thank you. Nicola, European Union exit update. I thought we'd exited.
Well, it's all done. Everyone would be really pleased to know. So this, we've just left it on for today to formally close down the EU exit reporting. We're no longer required to do any exception reporting. So I'm suggesting that we removed it from future agendas.
I'm sure we will all support that, Nicola, and thank you for your sterling effort in actually making sure that we did exit, despite the fact that most of us didn't want to exit. Thank you for that. Sam, remuneration and terms of service, terms of reference.
Yes, and no changes, just no material changes, and just to approve the terms of reference, please.
Yep. So if we're happy to approve, hands down. If we're unhappy, hands up. Duly approved. Thanks, Sam. Review of corporate objectives. Sue.
Thank you. We normally look at our corporate objectives on a regular basis to make sure that they're still reflecting the priorities that we're working towards. I think this year, the initial proposal is that we keep the existing corporate objectives that we've got, given that we are looking to, obviously this is our last year as a separate organisation, assuming that the bills progress through Parliament as intended. So it's really to get views on whether you're happy that we keep these as they are, and you can see the risks that currently associated with them, or whether you think we need to do any changes that might be helpful. The only thought I'd had since this report was initially proposed was whether we need a specific objective around facilitating the changes and the move towards system, and ensuring that in doing that we sort of protect and mitigate any risks that would disadvantage our population, or something along those lines. That I just reflected on while I was away, but obviously it's too late to consider putting anything in the report. But I would welcome views from anybody else on what you think. But obviously there's not much point investing in wholesale changes at this stage in our operation.
Thanks, Sue. Any thoughts or comments on it? Idris?
Just I think that seems eminently sensible on both counts, so I'm quite happy to support that.
So shall I work with Cheryl to draft up something in a more coherent form of words that we can add as a fourth objective for this last year? Fine,
Please do. Okay. Thanks, Sue. I've had any other business mentioned to me, but quick nip round the screen. Any other business from anyone? Perfect. Thank you. Well, it's 4 minutes to 11. I propose that we stop recording now and we meet back at 5 past 11 at 11:05 for the confidential governing